It's my pleasure this morning to welcome Sarah Whittley. Sarah is a clinical trial manager within the Department of Surgery and Cancer at Imperial College London. She's currently setting up the THRIVE trial, which aims to examine the most clinically and cost-effective thromboprophylaxis regime in patients undergoing superficial endovenous intervention, and is here to talk to you about this. Over to you, Sarah. Thank you.
Thanks, Jo, for the introduction, and thanks for the opportunity to present today. I'm Sarah, and I'm a trial manager at Imperial College London, and I'm currently setting up the THRIVE trial, which is an NIHR-funded study looking at thromboprophylaxis in individuals who are undergoing superficial endovenous intervention. So, as I'm sure most of you are already aware, varicose veins are swollen and enlarged veins, most commonly in the legs and the feet. And they're a common condition affecting up to 45% of the UK population. Endovenous intervention is the recommended first choice management for symptomatic varicose veins. And around 35,000 procedures are conducted each year. However, these endovenous procedures do present a unique VTE risk in comparison to other short-stay surgeries, and VTE occurs at a rate of up to 3.4%, which is actually a higher rate of VTE compared to post-operative VTE following open abdominal aortic aneurysm repair. And so in an attempt to mitigate this risk of post-operative VTE in these patients, around 2/3 of clinicians in the UK currently prescribe some form of thromboprophylaxis to their patients. However, there's currently no strong evidence-based guideline to support this practice, and there's actually the current guidelines are actually somewhat conflicting. So, for example, in 2022, the ESVS introduced a Class 1 recommendation for individualized risk assessments and then individualized prophylaxis for these interventions. However, the two trials that were referenced alongside this guideline, interestingly, are two randomized controlled trials. The first trial, however, does not include risk assessments, and the second trial only looks at moderate risk patients. On the other hand, then we have the NICE guidelines, which advise that these patients undergoing endovenous intervention generally don't require prophylaxis if they're at low risk for VTE and if they have a total anaesthetic time of less than 90 minutes. And finally, a systematic review and a meta-analysis that was recently conducted within the department at Imperial found a 75%, so they found a significant reduction in the rate of post-operative DVT following the administration of pharmacological thromboprophylaxis to these patients who are undergoing endovenous varicose vein intervention. And so we are lacking some robust grade A evidence to support the current practice in this patient cohort. And we do need some grade A evidence to inform future guidelines. And so that's where the THRIVE trial comes in. And the THRIVE study is aiming to establish whether in patients who are undergoing endovenous varicose vein procedures, whether a single dose or an extended course of pharmacological thromboprophylaxis decrease the risk of VTE, whether it's associated with an increased rate of bleeding, whether it's cost effective, and whether there's any signal to suggest that the agents affect the rate of VTE. So whenever we were designing this study, we surveyed clinicians across the UK to determine the current kind of regimens with regard to prophylaxis in this patient population. And what we found was that around half of all clinicians offer a single dose of low molecular weight heparin at the time of procedure. Around 1/3 of clinicians currently don't offer any additional pharmacological thromboprophylaxis. And around 15% of clinicians offer an extended course of pharmacological thromboprophylaxis, either with a low molecular weight heparin or a DOAC. And what we also found was that 100% of clinicians also will always offer compression as a minimum. Interestingly, actually, the clinical indication for the compression was for it was more likely for reducing bruising, reducing pain, and improving treatment success. So the compression offered is actually generally for clinical indications other than VTE prophylaxis. And so as a minimum in this study, all patients will receive compression. So this is a large randomized controlled trial involving 6,660 participants, all of whom will be randomized to one of 3 arms. So the first arm is compression alone. The second arm is compression plus a single perioperative dose of low molecular weight heparin. And then the third arm is compression plus a single dose of low molecular weight heparin plus an extended course of low molecular weight heparin or a DOAC. So following randomization, the IMP which is chosen for either of the intervention arms is dependent on your local preferences and your local policies. So we have tried to be as inclusive as possible whenever we were designing the protocol. These IMPs will be prescribed clinically, and they'll be administered in line with your local practice and in line with the summary of product characteristics. So for the single dose or for the extended course of prophylaxis, the low molecular weight heparin, which is chosen, can either be dalteparin, tinzaparin, or enoxaparin. And then the DOAC, which is chosen for the extended course, can either be rivaroxaban, apixaban, or dabigatran. So this is, as I said, it's a large randomized controlled trial, and therefore we will be recruiting from multiple sites. We hope to recruit from at least 40 trusts and clinics across the UK, both NHS and private, all of whom should already have an established practice in place, and should be delivering these endoVEnous procedures under local anaesthetic. And just at the bottom of this slide, I've listed a couple of the key stakeholders who have already agreed to support and recruit to this study. So the primary objective of the trial is imaging confirmed lower limb DVT, and that can be with or without symptoms, or PE with symptoms within 90 days of treatment. And then secondary outcomes include individual components of the composite, quality of life, mortality, cost effectiveness, and we will also do an exploratory analysis to look at the Department of Health Risk Assessment tool and the Cambrini score to see their usefulness in risk stratifying these patients, as there's currently no validated risk assessment tool for this patient cohort. And then safety outcomes will include any bleeding events. In terms of the eligibility criteria, any adults who are scheduled to undergo endoVEnous intervention of their varicose veins under local anaesthetic will be eligible, and treatment modalities include radiofrequency, laser, foam sclerotherapy, and cyanoacrylate glue. The exclusion criteria, I won't go through all of them in this talk this morning, but essentially any clinical indication for therapeutic anticoagulation will be exclusionary, as will any previous personal or first degree relative history of VTE, and any other contraindication to anticoagulants as well would be exclusionary. So apologies if this doesn't show up particularly well on your screen, but essentially this is the flow chart for the study. And it just outlines that patients will be approached, screened, consented and screened at site, and they will then be randomised to one of 3 arms at the site. Patients will also undergo a lower limb venous duplex scan at the site at 21 to 28 days post-procedure, where they will have any asymptomatic DVT picked up. And then at day 7 and day 90, patients will be followed up remotely by the team at Imperial. And at that follow-up, patients will be able to self-report any DVT and will also collect any quality of life data and a few other bits of data from them as well. So it's currently unclear whether asymptomatic screening for DVT following these endoVEnous procedures is a worthwhile investment for trusts and clinics. And so we would like to look into this as part of the cost effectiveness analysis. And so all patients who are randomised into the study will undergo a full lower limb venous duplex ultrasound scan at 21 to 28 days post-procedure. And this will most likely be conducted by the vascular scientists within your trust. However, any qualified, suitably qualified and trained professional will be able to conduct this scan to exclude asymptomatic DVT. Just briefly, in terms of data collection, participants can consent to the study either in writing or electronically. And as I said, the follow-ups will be conducted centrally by the team at Imperial at 7 and 90 days. And these will be done either by telephone, email, or SMS, depending on the patient's preference. Sites will also receive full training on all study-related procedures, and they will also be reimbursed £145 for all patients who are randomised to the intervention study and who are eligible, or £139 for each control patient who is randomised and eligible. And this study has been registered on the Associate PI scheme, so Associate PIs will be allowed at all sites at the NIHR's discretion. We submitted this study to the Ethics Committee and to the MHRA through the Combined Ways of Working system on IRAS in February this year. And we, as of last month, now have all regulatory approvals in place. And so we are now in the process of setting up all of our sites and conducting the SIVs ahead of recruitment commencing in January 2024. Recruitment will be open for 27 months, and so it is due to close in March 2026. So as I said, this is a very large but very needed study, and so we do need all of the help and support that we can get. So if you are a trust or a clinic, either NHS or private, who is interested in this study or would like to find out some more information, please do reach out to us. And you can contact either me directly, and my email address is listed here. You can contact the Thrive Trial inbox, or you can also reach out to the Chief Investigator, Professor Alan Davies, or the Co-Chief Investigator, Mr. Dan Paradise, and they'll also be happy to advise. Thank you very much, everyone, for listening. I'm happy to take any questions that anybody might have.
Thank you, Sarah. That was really interesting. And as you highlight, a really needed trial that we're looking forward to initiating and then eventually getting the results through. Please, if anybody had any questions, please do submit them. I have a couple. I'm aware that looking through this, you've mentioned that there is the extra scan that doesn't normally take place between the 21st, 28th day, and that's done locally. I'm sure many patients will be pleased about this, but will there be any reimbursement or support around that extra scan, please?
Yep, so as that scan isn't usually conducted as standard of care, we will reimburse as a research cost that scan, and that scan has been costed £100 for each scan. And yeah, as you highlighted, although logistically it may be a bit of a challenge for sites to sort of organise those not routine scans. I think the patients would actually be, that would be quite an incentive for the patients, as it will pick up any asymptomatic DVT that they otherwise wouldn't have picked up as standard care.
Yeah, thank you. And then obviously there's also the reimbursement per patient who's accepted depending on which arm, but yeah, which you made clear there.
Yep.
And as I mentioned before, this will be available to view again, so you can get those cost details down if you're needing to share them. Really good question come through. What are the barriers to recruitment? Because it must be difficult for sites to change their usual practice. So for instance, perhaps that extra scan.
So I would say probably the biggest barrier that we're finding out from sites at the moment is that ultrasound duplex scan at 21 to 28 days, just because it isn't standard practice. It is standard practice generally in the private sector, but not in the NHS. To try and overcome that barrier, what a few sites, including Imperial, have done is they've actually set up a sort of evening clinic each week to do these ultrasound duplex scans, and the member of staff, so in our case it's vascular scientists, will actually be paid directly for those scans as opposed to the money going to the trust, and that sort of incentivizes the staff as well as the patients to do those scans, if that helps at all.
If somebody's interested in taking this further and maybe coming on board, do they need to have a specific role in their trust, or can anybody from a trust contact you to find out more information, and who would need to be involved in considering?
So absolutely anybody can reach out to me. I'd be happy to hear from you. I'd be happy to advise on any queries that you have, or provide the protocol or any other documents, including the SOCAT, which would give you a breakdown of the kind of costs we've included in the study as well. So please do feel free to reach out regardless of your role in the trust.
And we're very aware everybody's under an awful lot of burden. Is this a great deal more work, or is anything there that's being put in to try to relieve as much work as possible?
Yes, so we are conscious that the healthcare system is under a lot of strain at the moment, and so whenever we were designing this study, we tried to be as pragmatic as possible. So for example, as I said, the IMP that will be prescribed clinically, so there's no need for a separate research prescription. The IMP, depending on which one is the local preference, can be chosen. And also the compression, which will be prescribed and already is prescribed as standard practice, will be prescribed in line with sites' local procedures. So the compression can include one-off or a combination of stockings, bandages, wraps, pads, or others. So we have tried to take as pragmatic an approach as possible to try and accommodate sites and relieve some of that burden. Thank you.
And just to reiterate, this is open to all clinics and trusts and private centres across the UK, is that correct?
That's correct, yeah. So any NHS trust, no matter how big or small, or any private clinic, so long as you currently do have an established practice and do treat varicose veins under these endoVEnous procedures, we would love for you to support the study.
Great. And so the first thing really is just to make contact with yourself or one of the people who are mentioned on this slide, discuss through any concerns or hesitations about your own site, whether it's eligible, and then hopefully move forward from that. But would be a really valuable trial and interesting to be a part of as well. I think we've exhausted all the questions, but thank you very much, Sarah. Really appreciate you coming here to talk about this. Thank you.
Lovely. Thanks, Jo, and thanks everyone for listening.
Thank
See you later.
And I'd urge everyone to contact Sarah and to consider being part of this THRIVE trial. Thank you. Bye-bye.